Good afternoon, everyone. I will be presenting case number 7. History provided was 31 years old male who presented with left-sided nasal polypoidal mass since 3 months associated with dull aching headache and a nasal tone of voice. This is the HRCT image PNS view. Here we can clearly see the polypoidal mass which is occupying the left nasal cavity, and the point to be noted is it is as well extending into the frontal ethmoid as well as maxillary sinus. It is a locally destructive lesion. Now this is the gross of the specimen which we received. It is showing a polypoidal mass which is glistening on appearance. I would like to invite the representative from Prince Ali Khan Hospital to discuss the case, Dr. Ketan.
Yes. Hello, everyone. Good afternoon. Am I audible?
Yes, sir, you're audible.
Yeah.
So I will be showing you 4 microphotograph of the case. This is the first one.
Yes. So here we can see a polypoidal lesion, which is lined by respiratory type of pseudostratified epithelium, and focally few of the other sections also showed the squamous metaplasia of the overlying epithelium. The stroma of this polypoidal lesion shows, as you can see, there are few cartilaginous islands which appear cellular. The other parts of the stroma appeared bit edematous, and they had scant chronic inflammatory infiltrate and few stellate blood vessels. Some of them were dilated also. Yeah. Yeah. On higher power, the similar findings. Yes, so as we can see, the cartilage appears mature. It's a bit cellular at places. There is a band of chronic inflammation beneath the epithelium. There are some areas of hyalinization also in the stalk. Yeah, further.
This is the last image.
Yeah, yeah. So over here, as you can see, the cartilaginous island is surrounded by a foci of spindle cell proliferation, which appear bland in morphology. They don't show any significant nuclear atypia, and there are scattered blood vessels around. So overall, the lesion didn't show any areas of necrosis, significant cytologic atypia, and any other epithelial component of epithelial proliferation. The mesenchymal proliferation component was this spindle cell, benign, banal looking spindle cells, and the benign cartilaginous island cellular. So we thought of this as an hematomatous lesion. So we would like to give it as nasal chondromesenchymal hematoma.
Yes, sir. Very well described by Dr. Ketan. Uh, very correct, sir. Any other opinion from the house? So, coming to a brief and quick discussion, our case, the clinical presentation and radiology, they both pointed towards malignancy. But when we saw the histology picture, it was very diagnostic and quite obvious that we were dealing with a case of sinonasal hematoma. Our slides showed mixed component, that is mesenchymal cellular element comprising of proliferating spindle cell and nodules of cartilage, which were showing various levels of maturation. Now, looking at the cartilage on the slide, we thought of two differentials, a chondro-osseous and respiratory epithelial hematoma and a nasal chondromesenchymal hematoma. But when we look the slides carefully, as in this image, we can see that the cartilage at the periphery, it is showing a smooth transition towards proliferating spindle cells, and the other various mesenchymal elements are also seen in the background. So we offered the diagnosis of nasal chondromesenchymal hematoma. Now, why we kept this case here is because the presentation of our case, both clinically and radiologically, was pointing towards malignancy. It was a locally destructive lesion, but histology was very obvious and diagnostic. Now, hematomas. Hematomas at a sinonasal location, they are very rare and uncommon. The pulmonary hematomas are the most common type which are being reported. We searched the literature until now. We found out that only less than 50 cases of sinonasal hematoma have been reported till date. So our case was quite unique. Then it was very unusual age of presentation. Such type of hematomas are common in infants and young children, but our case was adult, 31-year-old male. So again, we searched the literature. So in literature, we found out that till date, only less than 10 cases are being reported in adults. So this was the uniqueness of our case, the site as well as the age of presentation. Then lastly to remember is association with DICER1 mutation. So we have to be vigilant and keep a follow up. Currently, our patient after the excision of the mass is doing well and with no recurrence and with no fresh complaints. Thank you.